Okay, excellent. All right, so these are our topics for today: the daily checklist of connectivity troubleshooting, ergonomics, patient talk tracks mapping, lotion application, patient positioning, and use of pressure. Okay, so as far as our daily, our getting off to a good start is always a good thing each and every day. So we have a little checklist here that we like to go through. One thing I suggest is that you boot up the system as early as possible and make it part of your morning routine. It's not something that you as the technologist necessarily have to do. Anybody that may be turning on your systems in the morning can certainly do this, but it's always good to get the systems going just to allow for any troubleshooting that you may need to work through before the patient comes, and certainly keeping from having the patient to wait, or if things aren't going well, then you would need to reschedule, and that patient would not be waiting and hear the words, "We need to reschedule you." So just keep that in mind. It's a simple turning the system on. It only takes a quick 1 to 2 second push of the power button. And this also is the same for the shutdown process. You don't want to push and hold that power button. That would create a hard shutdown. It's just, like I said, a simple 1 to 2 second light push that will turn the system on. And it takes a few seconds for it to come on, and then same as turning it off at the end of the day. It takes a few seconds for it to shut down. As far as checking your connections, that's very important. You want to make sure that you've got the green light indicator, which will tell that all systems are go and you are good to go. Make sure that you have the lotion bottles filled and the linen stock. Typically this is done at the end of the day, but a lot of times you just want to double check and make sure you maybe didn't close out the system the day before. You just want to make sure that everything is good to go. And one thing that's extremely important that you want to do is verify your patient information, their name and birth date, on the image screen. And when I say the image screen, that's the actual screen where you see the image at the acquisition of the breast tissue. And you can verify it in the verify screen prior to, but always double check and make sure that that information is on the image screen is indeed that patient. We cannot change that information once you take one scan. That patient information is locked in. So make sure you've got that patient. Having the touch screen can sometimes, you can accidentally hit the wrong patient, so just confirm. Can't overemphasize that. All right, so as far as connectivity and troubleshooting, again, you want to make sure you get the green light for the connectivity. And the connectivity indicator network connectivity indicator is that green dot in the upper right corner. You can see the image here on the screen. And that just says, again, that everything's good to go. If you happen to get a yellow or red dot in that network connectivity indicator, that tells you that something isn't connected. In this particular case, you're getting a yellow dot, so you select that, just tap on that yellow dot, and then you'll get this drop down which will show what your destinations are and which ones aren't connected. In this particular case, you see that workstation 0 is not connected with, it has a red dot, but the other two are. So that's what indicates the yellow dot. If you see a red dot, then you're not going to have connections anywhere. So you'll want to make sure things that you can do to troubleshoot when you don't have a green dot is make sure that radiologist workstation has been logged into Windows. A lot of times that's the reason you don't have the green dot, and just make sure that those the radiologist's workstations are logged into. The radiologist doesn't necessarily need to be there, just someone needs to actually log into the Windows application. Check if PACS is down. Sometimes PACS can be down, and that could be a reason for that. So you could call your IT person just to make sure that PACS is up and running. If that isn't if that isn't the issue, then just make sure your Ethernet cable is securely connected, whether it's at the wall or into the ABUS system. And that cord can easily get jiggled loose, or if you're sharing that room with a handheld system or another system and you have to interchange the cable, just make sure that that connection is good. And another thing too, sometimes you may have multiple ports in that room. So somehow label that port to make sure that you're connected to the right port. And just get that click as you hear that little plastic piece connect to the wall or to the system. And another thing is make sure that the Ethernet cord is not damaged. Sometimes it can get damaged, whether it's wear and tear or if the system is rolled across it back and forth. Just make sure that that's not damaged, because that could create a problem. As far as back to if PACS is down, remember that you still can image the patient. You can still do the images if PACS is down. What will happen is you will get that yellow triangle in the completed work list screen. So hopefully each day you guys are checking, or after each patient you're checking to make sure you get the green check mark. And if you don't get that green check mark, you'll get that yellow triangle. And all you need to simply do is, once you know you've got connections, all your connections are good, just select that yellow triangle in the completed work list, and then all the way over to the right, you'll see the computer monitor. Select that, and then it will give you your different destinations, and then you can select which destination it needs to go to, and just determine which connection wasn't green at the time that you scanned the patient. All right, so as far as ergonomics are very important. As technologists, many of us work in pain. So that's the whole principle behind ABUS. It is overall a very ergonomic system, but there are a few things that I want you to be mindful of as you scan. Position that patient closest to you on the bed and bring them close just even before you start positioning them with the wedge. Just have them scoot close to the edge, pretty much right on the edge. Just let them know you're not going to let them fall off, and just be real close to them there. That will help you from not having to reach too far. Make sure the bed height is at a comfortable level. Every technologist is different in height, so you don't want to be straining, stooping, or on your tiptoes with your shoulders up by your earlobes. Just make sure that bed is at a good height, typically waist high, and that allows you to be able to see into the membrane and make sure you're covering all the tissue and make sure you have good contact with the membrane. Position the monitor for easy access. That monitor arm can typically stay in a stationary position, and then all you have to do is just rotate the monitor from side to side, depending on which side of the bed you're standing. So make sure you keep that arm, like I said, in a good stationary position, and then all you have to do is simply tilt the monitor to one side or the other, and that keeps you from having to strain your neck to see the images as you're scanning. Let the system control the pressure. Manual pressure isn't necessary, and that's kind of the whole principle behind ABUS. We don't want to use the manual pressure because then that reproducibility factor is taken away. So let the system do its thing. And as far as that goes, we have 4 pressures on the system. And I say 4 in that 1 can be free, but again, remember that that free pressure doesn't allow you to reproduce from year to year. So the low pressure is 7 pounds The medium pressure is 14 pounds and the high pressure is 21 pounds. Remember to relax your shoulders and use a light hold on the scan head. If any of you have trained with me, I try to remind you of that over and over and over. Just relax your shoulders, and you can tell a big difference when you loosen your grip on the scan head too. So just remember, you have to maintain a light hold on the scan head and keep your shoulders relaxed. You have to tell yourself that a few times though to make it stick. Push the elbow of the scan arm away from you while scanning. That elbow is the joint on the scan arm that allows the scan arm to move back and forth. So just remember, if you let it extend too far, you are struggling to get the scan arm to do what you need it to do. So just reach up and push that elbow away from you. That, like I said, allows you to have more mobility with the scan arm, but it also keeps you from hitting your head for those tall technologists. I'm not one of those tall technologists, but sometimes if you are taller, that scan arm can get in the way, and especially when you're applying the pressure, it's weighted pressure, so the scan arm slightly moves with each pressure, so just be careful you're not hitting your head on that. Okay, describing the ABUS exam to the patient. They don't know what they don't know, so you want to be sure and explain things to them, especially if it's the first time they've had an ABUS. So be sure to confirm to them that they can breathe normal. They don't need to hold their breath during this exam. And we do tell them not to talk. Of course, they can talk throughout the extent of the exam, but we do emphasize we don't want them to talk during the acquisition part. So I like to explain to them that we're going to be applying some pressure. We keep you in a certain position for all views on the right side, and then we'll do the same for all views on the left. And just explain that pressure is applied, and we just want you to hold still and don't talk during the acquisition. And you'll feel that transducer move across the breast, starting in the middle, going towards your feet, and then towards your head. So just a kind of a simple talk track. To get optimal images, it may require more pressure, but make sure the patient's comfortable. You know, ideally we want to get as much pressure as possible, but we also don't want the patient to be uncomfortable. So watch their body language, watch their facial expressions. Be sure to emphasize to them that it's only 45 seconds per scan, and that kind of gives them something in their mind to think, okay, I can do this for 45 seconds. Keep your explanation simple as far as why we're doing the exam. We like to talk about the snowball in a snowstorm reference, simply by saying that cancers, dense tissue shows up white on a mammogram, and so does a breast cancer. Breast cancer looks differently on ultrasound. So you can go into more depth, but just keep it simple. Emphasize to them that the ABUS does not replace their mammogram. They will ask that. I'm sure you've gotten that question many times, but just tell them that it doesn't replace a mammogram. Mammograms are still gold standard for finding those tiny microcalcification breast cancers. But if someone has dense breast tissue, it is considered a complete screening when you get an annual mammogram plus an ABUS. So again, those are those patients that are the category C and D density. This is our density quick card that I think is a great tool to use. It has all the simple facts that we just kind of talked about. I don't think I hit all of them, but it's a little bit more statistics that you can go into with them. But these pictures pretty much describe what you're talking about. You can see the differences in the different categories, and let them know that their mammogram will define the category that they are as far as the density. And hopefully you guys all have these little pocket cards. I know all of us like to try to leave them with you during the install training, but if you do not have them, reach out to one of us. We can get them to you. This information also came with your marketing kit whenever you got the system. So look for that. And and all of you should be, hopefully, on the ABUS Club, you can reference these cards in the marketing corner on the marketing corner tab of the ABUS Club. So if you don't have information or you don't have a login for the ABUS Club, please reach out to us. We want to make sure that you can get access to that. It has a ton of information that you can use, whether it's webinars, additional content, whether it's doctors' webinars, articles, like I said, marketing information. There's all kinds of information on that. Okay, so as far as mapping out the scan, plan your approach by using that membrane. So just pop the membrane off of the scan head and use it to map out the breast tissue. The goal is to acquire the most breast tissue in the least amount of views, making sure that the nipple and central tissue is overlapped, which is where the majority of the dense breast tissue is. So this will just it saves you time because you can determine if there's areas that are more difficult for contact, and it will help you determine how many views you need to do. And it identifies those areas that require more lotion, whether it's those deep axillary pockets in the breast, whether it's a person that has a very thin body habitus where their ribs are protruding off the sternum. It just kind of gives you a good idea to help you know where you need to put that extra lotion and just kind of make things go a little bit smoother. These are the different views as far as mapping. Our 3 standard views are AP, lateral, and medial. Again, noticing that that central tissue is overlapped at the nipple. This is an image of the 2-view scan, where this is in those very, very small-breasted ladies where you can incorporate the AP and the medial as one view and then do the lateral view. I just caution you in doing this. It's kind of rare that you would do it on small-breasted women. Definitely an option, but be careful that you aren't missing tissue whenever you do this, the 2 views. As far as the quadrants view, this particular view shows image, or this can be seen with the 2.0 users. They have them labeled as lower outer quadrant, upper outer. The medial view is kind of the lower inner quadrant, and then the upper inner quadrant. This is typically done on ladies that are larger breasted, obviously, but sometimes more wide, large breasted, as opposed to larger breasted and taller, where their breast kind of is more narrow. So use this view in that particular case. On the 1.0 users, you would do your 3 standard views and then add a superior, which a lot of times will cover larger breasted women also. Oops, the other way. And then we have the implant view. So you will do the 4 views on implants. They're always a little challenging. And this is on the ABUS Club, there is a little video that talks about doing implants too. But you want to do your 3 standard views and add the superior. Again, implants can be challenging. You do what we kind of teach you the standard way to do it, but sometimes you have to do what you have to do to get it done. All right, so filling in the gaps with the lotion. Initial lotion application. We want to emphasize we're glazing, not frosting. For the users that have been around a while, you know that we used to put a lot of lotion on, and we are backing off that. We've learned over time that it's not necessary to use that much lotion, and we also know that it helps our cleanup process go a lot quicker. So glaze, don't frost. Just use the lotion applicator to do a quick spreading of the lotion. You don't have to use a lot of detail. You could cover the breast tissue. I like, especially on the initial AP application, I'll just kind of cover the entire breast and go about 2 fingers width past the breast tissue borders, and that will ensure that you've got all of the contact that you need. Fill in the low contact areas with that extra lotion. And then you'll want to do the lotion, or you'll want to fill in those low contact areas at the lumpectomy site where you have little divots or areas of low contact, because you want to make sure that that membrane is going across the breast tissue with no, you just want to make sure you have contact. We use the lotion, it's necessary, and you can emphasize this to the patient. We use the lotion to provide an interface between the skin and the transducer for the sound to travel. So that's the purpose for the lotion. When that lotion is not applied, then you get those black artifacts or those black curtains that we don't want to see. So along the sternum, a lot of times I like to fill in like a bead of lotion for those patients that have a prominent sternum and very bony rib prominence there too. You can also use the post-scan lotion footprint. And that is where that membrane, after the scan's completed, you lift up the transducer head, and then you see that membrane implant. We kind of talk about, it looks like kind of that snowplow effect. If you look at the image on the breast, you can see where the transducer scanned. So that gives you an idea to determine that you did cover all of the tissue that you needed to, or the tissue that you still need to cover, whether it's superior, inferior, lateral, medial. This is a picture that shows a good lotion application, and again, you're just glazing the breast tissue, not frosting, and making sure that you do have, where you have to fill in the gaps, put that extra lotion, but where you don't need to fill in any gaps, just make sure you've got a glaze over the breast. Too much lotion is not always better. And this was an indication of where you've got too much lotion. And it gives you kind of a false sense that the membrane is actually making contact. So as you can see, you do get some artifact in that image. So you just want to make sure that you don't have too much lotion in the areas that you don't need the extra lotion. As far as lotion tips, store the bottle upside down, and that helps to keep air bubbles from being trapped in that lotion and creating potential artifact. The lotion holders on the system, they're not warmers, but this exhaust or the heat from the fan of the ultrasound machine does kind of create a little bit of heat that will warm up bottles of lotion. So that's a good place for holding the lotion. You always know where that bottle is, and it does kind of take the edge off of room temperature lotion. Room temperature lotion can be helpful for filling in areas, and it has a thicker consistency. So sometimes those areas that you want to have a good buildup, that you don't want, you want that lotion to be more viscous, so to speak, then you would use a room temperature lotion. If you are using a warmer, please keep it at a low warmer setting. That will ensure it from not being extremely runny. That runny lotion, as you know, is hard to control, and it really doesn't serve much of a purpose if you can't keep it in the spots that you need it. And also, a lot of times, if that lotion's been in that bottle in the warmer for a long period of time, it can start kind of clumping up. So just keep an eye on that. Another thing, good tip is to maintain a spot where you always have that lotion applicator, whether it's during the scan or after the scan. So a good pro tip is to use a small washcloth and just kind of fold that lotion applicator in the washcloth as you're using it to scan the patient or as you're doing the patient. That way you know where the lotion is. It also keeps me from sticking my elbow in it or the patient possibly placing their hand or arm in that as well. And as far as keeping it a spot, I highly recommend keeping like a jar or some tray or something close by the machine, or that you can always know where that lotion applicator is. I get a lot of customers telling me that they've lost their lotion applicator, and chances are it did get thrown away in the linen. So just maintain a spot where everybody knows where that lotion applicator is. That way you're not losing it, or you just know where it is. And if you need the ingredients of the lotion, we can provide that for you. Just reach out to one of the application specialists and we can certainly give that information to you. This is a slide that shows the cleaning process, and it is actually the video that's on the ABUS Club. And as you know, it is very simple. I like to take off the clear plastic shield first and set it aside. Then I like to pull that membrane off over the bed and the old linens. That way you don't risk getting any lotion on the floor or anywhere else. And then I like to use a dry cloth to wipe off the lotion first, as much as you possibly can, and then use the wet wipes, the approved wet wipes, to clean the system, and then dispose of all of the wipes, the membrane in the trash, and then just gather up the linen and put it in the linen bin. And then just reassemble the system, putting the clear shield back on, and always pop that membrane back on. Once you're finished, then you're good to go. Again, you can review this video on the ABUS Club, and that website is right at the top of the screen. All right, patient position. This, to me, is very, very important for getting the images that you need. It's critical for making sure the placement for the breast tissue is level, and that it just helps. Once the patient's in the proper position from the very beginning, then you can proceed through the exam quickly. If the patient isn't in the best position, then you may struggle. So just make sure that you've got that patient in good position, and patient comfort is important. So use the pillow as a lateral edge for the arm placement. Just pull it closer to you and kind of at an angle. Use rolled up towels or a wedge underneath the arm or the shoulder that will kind of help support that patient. And you can either put it under the pillow or you can put it right underneath the arm. Make sure your positioning wedge is just below the axilla. That's important because if you've got it too high, then that obstructs the patient's shoulder from having good mobility, which you may need to use to get proper positioning. So just make sure that wedge is just at the axilla, kind of at the crease of where the arm comes down. Patient position should not change if at all possible, and I can't emphasize this more. We want to make sure that patient is in that same position for all the views on the right and then all the views on the left. So again, that's kind of where your mapping comes into play to make sure that you can get all the views adequately, but you just want to make sure that you get that patient in the proper position, because you don't want to change the position, because that shifts the nipple position, which is what the doctor or the radiologist uses for location determination of any pathology or anything that they may see on the image. Have that patient raise their arm about 90 degrees, and then you can move the image or move the arm as needed. It's amazing how just a little bit of shift in the arm position can change the position of the breast tissue for you, working for you or against you. So kind of play with that and make sure that you've got that patient in the or the arm in the most optimal position for scanning. And again, I didn't mention this before, but always ask the patient if they have any shoulder issues, because you don't want to be having them adjust or make position changes if that is painful or uncomfortable for them. And I like to have them move their arm instead of me move their arm for them, because you don't want to do anything that may hurt them. And there are times where you may benefit from having the arm down by the patient's side, especially on those smaller breasted patients, where it'll create a larger amount of breast tissue and just give you a little easier access to those smaller breasted patients. And typically bringing the arm down for that medial view doesn't change the position of the nipple or shift that breast position too much on those smaller breasted patients. Just be aware of that. If it does change that nipple position, you don't want to alter the arm position. All right, the importance of pressure alleviates shadows. Adding the pressure, I like to explain to the patient, helps to level the breast tissue and decrease shadow artifacts. So the emphasis with adding pressure is it gives better image quality for the radiologist, and it also increases the contact or increases the amount of breast tissue that you can cover. Pressure can be added to the patient for individual tolerance. So again, watch their facial expression and their body language. Don't push it too much. Listen to the patient. Let them know that they can tell you if something's uncomfortable, and then you can just back off the pressure. But also, I do kind of emphasize that at the beginning in my talk track to say we do use the pressure for the two reasons: better image quality and better tissue coverage. And a lot of times I think that sets in their mind that, okay, that is important, I can tolerate this, and they're pretty flexible and pretty compliant. If there are issues, if the scan starts and they are struggling with discomfort or having a coughing fit or whatever situation may create image artifact, you can hit that abort button, and that will immediately release the pressure and stop the scan. Remember, on that abort button, you have to hit it a second time to recalibrate the system to make sure it's ready to go for your next view. The importance of pressure. This is a good image that shows the differences. The image to your right, the right of the screen, is an image of high pressure. If you look at the image to the left, you can see how you see black curtains on each side of the breast. And you can also look on the coronal view and just see that you haven't covered quite as much tissue. So the image on the right is low pressure and the image on the left is high pressure. So that just gives you an indication of how much more tissue you are covering and how much better image quality you can see. That concludes our presentation. So thank you all for being champions in the fight against breast cancer. And I appreciate all that you all do again. And thank you for taking the time out of your busy day on a very busy time of the year.
Okay, thank you, Christy.